This is Dr. Bhojraj Adhikari. I am physician consultant Bharatpur Hospital. I belong to Vice President of Nepal Health Research Council. Thank you.
So the first question, can you please explain us about the features of the hospital which was inaugurated today?
Thank you so much. This concept has emerged to make a quarantine type isolation hospital in the premises of Chittagong Udyog Sangh. Due to the feel of insecurity and the condition which has been arising all over the world, the disease corona, which has been epicenter in China, has emerged into the Europe. It has all damaged to the Europe, and it has come to the India as well. When it came to the India, the cross-border issues and all the Nepalese which are outside of the countries, they are traveling too much to the Nepal. Then what we realized is, like, recently there are few cases which are reported to have been serious with fever, cough and respiratory distress. Probably they may be COVID, for whom the admission section is not there. Yes, we are preparing a lot of isolations and fever clinic, but they are not prepared to treat for the complicated and dangerous type of the cases. So we thought that why not we make a hospital which is wholesomely treating all the health aspects. Like WHO says, we have to have a primordial aspect, primary aspect and secondary aspect. As a primordial aspect, we educate people not to come to the hospital, see the symptoms, identify the danger signals, and then only come to the hospital. That is a primordial prevention. Primary prevention is if they have some symptoms, we from the part of hospital advise them to have some symptomatic management at their home. When they are not managed, they come to the fever clinic, and when fever clinic suspect the cases, they all are designated to come to the dedicated type of hospital, which is designed as a temporary corona hospital, which is a specific hospital designed for preventing this type of epidemic. And the whole project may last up to maximum 3 months, because we are at the peak of the disease. If we see the longitudinal epidemiology of the virus, it mostly long lasts for around 3 months. So we did not have a long time to make a decision. So we, the Bharatpur Metropolitan, and all the stakeholders, including Udyog Sangh, Udyog Banijya Sangh, all the private sectors, government sectors, cancer hospital, we are all gathered in one forum. We made a committee. That committee designated a hospital which is to be made in this Bharatpur 10 premises. And this hospital has 4 sections. One is just OPD sections to isolate and to confirm the diagnosis. Second is to have an investigation clinical testing scenario. Third is they are observed and admitted, and if they are positive, they are taken to the SDU, high dependency unit. And fourth and last is the high level intensive care unit, which is given to the patient who are coming with the respiratory distress and suspected, and to the patient who are already positive to the COVID.
Secondly, in how many days is the hospital completed? The construction?
This hospital is made within the project assumption of 3 days, and within the 11th hour of 3 days target ultimatum, we have been made it to come true, because we thought it 3 days back that we will make it, and there was already the premises of Udyog Sangh where we can almost occupy around 5,000 people. If we see the WHO standard criteria, we can make around 500 bed here. So this much premises without the dense population around. There is no building at around in Bharatpur municipality, and people should not think that they are isolated. People were giving argument that they should be in Bageshwari, they should be somewhere jungle, somewhere in the hotel. But we thought that they should not be too much isolated. They should not feel that they are neglected. So this is the place which is at the core of the Bharatpur. It's Bharatpur 10. This is the institution. This is the place where the people are designated to the benevolent act, and is made for only for trade and other purposes on a temporary basis. So when this institution is already there, we thought that this will be the best place.
So does it fall under the criteria of the WHO, as there is a school nearby and some public spheres around the hospital, the temporary hospital which is?
See, this temporary hospital, if we see the premises of hospital, even where we are staying now, this is around 300 meters far from the hospital, but we are in the premises of Udyog Sangh. And the population, if we see the nearest population, maybe half kilometer or nearby, and only the roads are there on the all 4 corners of the this Udyog Sangh premises. So I don't think any sense of having transmission. If this is transmitted not only by the droplet infection but by the flow of the air, if the science comes like that in the coming future, there may be few risks. But at the current understanding, we do not believe that this premises is risky for transmitting the disease to the common population.
Secondly, we don't have proper borders or the areas or walls to curtail the area. And for example, if a patient is admitted in the hospital, and it has been experienced in Kathmandu also from Teku Hospital, many of the patients they have ran away from there. What sort of precautions have we adopted?
We have a 3-tier system of security for those type of patients and populations. First is like the gate itself is designed that there will be a security people. There are 2 gates, only 2 gates will be open maximum, mostly 1 gate, where many security, because of that experience, 4 security people will be on outside of the gate, and 2 security people will be with the dress PPE inside the hospital, 2, and we will be in a CCTV surveillance, so that minimum problem also will be approximated earlier, and we can anticipate that. And third thing is like we have the first thing is like when the disease came, there were a lot of cures. People were not convinced with the symptomatology. Sometimes they are forced to check, but we are not doing that. We are convincing them. We are telling what is corona in the multiple tier system. They are told in home, they are told in fever clinic, they are referred on that way, so they are convinced mostly. And if there are other things to be taken precaution, we are doing simulating exercise for minimizing those type of mischiefs to happen. So I hope that these things will not happen in this sector.
When talking about the Chittagong in particular, it is not only a hospital hub but also a tourist destination. Many of the foreigners, they usually come to the Chittagong. Like the foreigners who are in Nepal or the Saura, if they got contracted with the virus and they are brought here for the admission, the main problem it comes is the language. How we have prepared for the language. Like for example, a Chinese got infected, then we might not have that sort of linguistic capacity. So how you have thought to
that's very true. See, if we think of Chinese who has recently come to the Nepal, there is no provision because airport is already closed. If we see the Chinese who are already come 2 months back to Nepal, there is also no problem. They behave like us. So if somebody has a linguistic problem, especially English and other languages, we do not have problem. This is a very minimal issue. But the thing is like the medicine is a body language. This is not only the speaking language. Medicine is a body language. Whenever they are presented, when they are talking, we see whether they are febrile or not. Our temperature measurement mentions that they have fever. Whenever they present with the shortness of breath, cough, then we see that in front of us. So not only the language. Yes, that is one of the barrier. But language does not restrict us to measure the temperature, to see the cough, to see the breathlessness. So if we see this triad, we definitely do the test and we convey the result.
Okay, so how many doctors are to be mobilized in this hospital?
For the first 3 days, we are not starting ICU because of lot of our experience, and we want that it should be the best. So meanwhile, we want to preserve our PPE also. So in the OPD, general ward and other sections, we are utilizing very minimal population. We are updating every 3 hours how many patients come to the hospital. And we are giving the duty to the medical persons accordingly. We are not keeping 8 hours duty because they will be more in hazard. So we will keep 2 people in each shift. So there will be around 8 people working in the hospital for the first 3 days in one shift. Whenever we start ICU and the patient flow increases, we have a capacity of making 3 OPD sections, having 50 bed admission and 10 SDU, 10 ICU, and we have a expansible capacity of more than 300 beds in these premises. And for that, and with the decision of Nepal Medical Council and the government decision, probably less serious cases, routine cases, elective cases will not go to the hospital from Sunday. If so happens, our lot of health workers, doctors, sisters and laboratory personnel, they all will be not occupied there because we will not run OPD there, routine OPD. So these all people will be occupied here for a dedication to maintain the patient room. So, and this not only one hospital, this is not government, this is not private hospital. This is designated by Metropolitan, held by Metropolitan and run by Metropolitan, but this is a unique hospital, which is the common forum, treating forum of all medical college, hospitals, small hospitals, and even the health units of the district.
So it always has been, like you said about the hospital, you will be operating different shifts with 2 doctors each, and the security of the doctors, it always has become the major concern because the doctors in India who were treating the COVID patients, they got infected. Like in China, also the first doctor to identify the case, he died later because of the COVID virus only. So what precautions have we adopted for the doctors?
See, first thing is that we are a first frontliners to treat the patient. But it's also true that we are human. We are not different from the patient. When we are treating the patient, we already think that we will be infected. We can be infected. But thing is that what precaution we can take is like in the beginning days when the China was on the problem, and the doctor who first time warned the world, he did not know the nature of the disease. That time nobody used to take up preventive measures. And then India comes. The doctors attacked by the disease, positive cases are high, but they are not fatality. Mortality is very less. Morbidity is there, yes, of course. We can have a minor disease. We can have minor COVID. We are prepared for that. But we should always be ready to minimize the risk. So we will have a PPE. Till now we have arranged 200 PPE for health workers and 200 PPE for the patients on the WHO standard criteria for the health workers. And we will be maintaining the CCTV surveillance unless and compulsory. We will not be frequently visiting to the patients who are stable. In ICU, we will design it in such a way that we will not repeatedly use the things. We will have a disposal system of single disposal system. Our ward will be mostly occupied by the stable people who can listen to us from the CCTV surveillance. So we have given training for our healthcare staffs today morning, and we are keeping on training them, simulating them. And we have learned all the mishaps happen in Italy, China, and even recently in India. So that thing itself makes us lesson. So what mistake had happened, and that thing can repeat to us. So those things we are trying to minimize.
So talking about the PPE and other things, like it has been a shortage in India itself, and China is donating India and the Italy itself. So how many PPE would be required?
See, in the beginning days we will require only 16 per day, 16. I hope. In the beginning days, 1 to 3 days. But when flow of the patient increases, we cannot imagine. It can increase very high if we follow the WHO protocol. But I heard that the central government is purchasing 15,000 PPE. I hope when we are so much dedicated to treat such type of patients, and we are designed very uniquely in Nepal, the government will listen that we need at least 1,000 PPE from their purchasement. If they buy 15,000, I think we have a right to ask them around 1,000 PPE. So, and if we do not get the 100% safety measures of PPE, at least we can get some. And there are a lot of first copy made. I don't know the safety of them, but at least not to get something is better than not to get. So I hope that problem will also be solved. If PPE are less, we will minimize the health workers involved in the treatment, but we will give service.
So does our hospital have that capacity to test the COVID patients? Like if some person who has some symptoms of COVID comes to the hospital, and the swab or the samples will be sent to the Kathmandu, or it will be tested in our lab?
We cannot test now currently. Only whole Nepal, only NPHL test for the COVID. Rapid tests are not designed and not authenticated by WHO. Serology test we are not supposed to do. Only RT-PCR, which is very reliable test, and it cannot be established in all the centers. I hope that this should be designed and made available in our setup. I had some clue that we can do it, but till now, whenever we collect the sample, we are only compelled to collect it within 1 hour, maintain the proper cold chain system, send it to the NPHL and get the report.
Out of the context of hospital, can you please explain about what are the tests that are required to confirm whether the patient is infected with the COVID-19 or not?
Okay.
First
is a clinical scenario. In clinical scenario, we ask travel history, although it's not significant nowadays more, but we ask travel history for the contact tracing as well. Second is we ask their symptomatology. Fever is almost in 90 to 95% people, so we ask whether fever is there or not, a cough, and shortness of breath. So when we ask these 4 questions and he is eligible to undergo the test of COVID, we parallelly simultaneously do few investigations to have an idea regarding his immunity power and problem. like we do the complete blood counts, we do liver function because they are liable to get the liver problem and kidney problem in the COVID. So we do liver function, renal function and CBC, and we do the chest X-ray. If we see the chest X-ray, patchy shadows, bilateral, there are CT scan guidelines also, unless we get this RT-PCR. CT guidelines, like Chinese government also and Chinese policymakers also designed it that unless RT-PCR is available, they can immediately doubt on the basis of CT. They have said the ground glass opacity bilaterally is one of the laboratory marker of this COVID. So CT scan will be done. But for the meanwhile, I have to say sorry that CT scan machine is not joined. But with the provision of doing direct RT-PCR, doing the all blood necessary investigation and chest X-ray, we can handle the cases.